Behind the growing global burden of obesity-linked cancers lies a disturbing and underrecognized truth. Women are disproportionately dying. While obesity is a known risk factor for both sexes, women, especially those past menopause, face a higher risk of developing and dying from certain obesity-related cancers. This is not a statistical anomaly, and it is not just about differences in body fat percentage. It is a complex, gender-specific vulnerability that public health systems and cancer prevention efforts have been slow to address. The evidence is increasingly clear. Postmenopausal breast cancer, endometrial cancer, and ovarian cancer, all of which are strongly associated with obesity, are among the leading causes of cancer death in women worldwide. In particular, endometrial cancer has one of the highest relative risk increases from obesity of any cancer, with obese women facing up to 10 times the risk compared to those at a healthy weight. Yet this staggering reality receives little attention in mainstream cancer education efforts. Biologically, the female body responds differently to obesity than the male body, especially in how fat tissue interacts with hormone production. In women, adipose fat tissue is a major site for the production of estrogen after menopause. This estrogen is unregulated by the ovaries and can circulate in excess, fueling hormone-sensitive cancers like breast and endometrial cancer. The more body fat a woman carries, the more estrogen her body may produce, creating a direct hormonal pathway to tumor growth. Chronic inflammation, a hallmark of obesity, further compounds the risk. Inflammatory cytokines and adipokines such as leptin and interleukin-6 are elevated in obesity and have been shown to promote cell proliferation and inhibit apoptosis, cell death, laying the groundwork for cancer development. While both men and women are affected by this inflammatory cascade, women's risk is magnified by hormonal interactions that make certain tissues more vulnerable to malignant transformation. This biological interplay is made worse by diagnostic delays and disparities in treatment. Symptoms of endometrial or ovarian cancer, such as abnormal bleeding or bloating, may be overlooked or misattributed to other conditions, especially in obese women. There is also growing concern that healthcare providers may underrefer obese women for screenings, or that imaging quality may be compromised by excess body fat, delaying diagnosis. These delays matter. Obesity-related cancers in women are often caught at later stages, when treatment is less effective and survival rates plummet. Treatment itself poses unique challenges for obese women. Chemotherapy dosing is notoriously complex in heavier patients, and underdosing is a known issue. Surgeons may face greater complications in obese patients, leading to more conservative treatment plans or outright denial of surgery. Radiation therapy also becomes technically more difficult. These clinical barriers are not theoretical, they are real and present obstacles that compromise outcomes. And yet, treatment guidelines often fail to account for these differences, leaving obese female cancer patients at a disadvantage. The situation is even more dire in low-resource settings. In many parts of the world, the rise of obesity in women has outpaced the growth of screening programs and health infrastructure. In these regions, women are more likely to be overweight due to cultural, economic, or reproductive factors, and far less likely to receive timely cancer care. This translates into a devastating equation: more women at risk, fewer interventions, higher mortality. Social and psychological dimensions compound the issue. Obese women often face more stigma in healthcare environments than men, and this bias can affect the quality of care they receive. Weight-related shame may also deter women from seeking regular medical checkups or cancer screenings. Many report feeling dismissed or judged during medical visits, especially when their weight is automatically blamed for all health concerns. These subtle forms of bias erode trust and allow deadly conditions to progress unchecked. Despite the growing burden of obesity-related cancer deaths in women, public health messaging remains largely gender-neutral or focused on men's cancers like colorectal or liver cancer. There is little emphasis on the hormonal or biological pathways that uniquely affect women, and even less acknowledgement of the systemic biases that prevent women from accessing timely and effective treatment. This silence is costing lives. Addressing this crisis requires targeted, gender-specific interventions. Cancer prevention campaigns must highlight the link between obesity and women's cancers with the same urgency as they do for tobacco or genetic risk factors. Routine care for women, especially in midlife and after menopause, should include not only cancer screenings but weight assessment and tailored guidance on maintaining a healthy weight as a cancer prevention strategy. Healthcare providers must be trained to recognize and overcome implicit bias in treating obese patients, especially women, and clinical trials must include more obese female participants to guide evidence-based care. There is also a broader cultural shift needed. Obesity must be recognized as a modifiable risk factor for cancer in women, not as a cosmetic issue or personal failing. Until society reframes the conversation to reflect the deadly seriousness of the issue, women will continue to bear the brunt of a preventable epidemic. Obesity-related cancer deaths in women are not an unfortunate coincidence. They are the result of intersecting biological vulnerabilities, medical biases, and systemic failures. And unless we take deliberate, focused action, more women will continue to die from cancers that could have been prevented, detected earlier, or treated more effectively. This is not just a gender gap, it's a public health emergency hiding in plain sight.